Hello and welcome to Better Man Clinics, the podcast where we talk to actual experts to address the questions that men want answered, but are either too embarrassed to ask or simply don't know who to ask. Before we get started, I do want to caution that the conversations on this podcast are for informational purposes only. They don't represent a medical consultation, nor do they present medical advice to individuals. Rather, we hope that the podcast empowers men with the knowledge and confidence to address these issues with their healthcare providers. As with any medical or wellness issues, you should always consult with your healthcare provider before beginning any type of treatment or preventative intervention. With that being said, in this episode, we discuss headaches, a problem that most, if not all of us, have had at some point in our lives. For most people, a headache is a minor inconvenience, relieved with an over-the-counter medication. But what happens when the headache does not go away or keeps recurring? What do we do then? What can we do to avoid headaches? What home remedies and alternative therapies may be worth trying? And when is it time to see a doctor? And when you do see a doctor, what are the long-term treatment options? To answer these questions and many more, we turn to a true expert. Dr. Teshamae Monteith is an associate professor of clinical neurology at the University of Miami Miller School of Medicine. She is the chief of the headache division and the program director of the United Council of Neurologic Subspecialties Headache Medicine Fellowship Program. Dr. Monteith received her medical degree at the University of Miami and then completed her neurology residency training at NYU. She then pursued 2 fellowships in headache medicine at Thomas Jefferson University and UCSF. Dr. Monteith currently serves on the editorial board of the American Migraine Foundation and the American Academy of Neurology's Brain and Life magazine. She is the headache topic chair for the 2022 American Association of Neurology annual meeting scientific program abstract review process. She is also a co-recipient of the American Academy of Neurology's Palatucci Advocacy Leadership Award and the American Headache Society's Wolff Award. She has lectured both nationally and internationally, authored numerous publications, and has provided peer review of both national and international journals. Dr. Monteith has served on several advisory boards for migraine and cluster headaches. She has hosted over 80 podcasts for the American Association of Neurology, the Neurology Journal, Neurology Minute and Continuum audio for topics important to neurologists, including brain health, migraine, cluster headaches, and secondary headache disorders. And now, without further ado, I bring you our conversation with Dr. Teshamae Monteith about the management of headaches. Hello, and welcome to Better Man Clinics. Today, we're going to be talking about headaches. We all get them. We've all gotten them at some point in our lives, and most of the time, we might ignore them. We might do some home remedy or take something over the counter, and they go away. But what if they don't? What if they get worse? Or what if they just keep coming back over and over and over again? Is this something that we could prevent? Are some men more prone to it than others? What treatment options are available? And really, when is it time to see a professional? Fortunately, today, we have just such a professional with us to answer these and many other questions. Dr. Teshamae Monteith is an associate professor of neurology at the University of Miami, and she also is the chief of the headache division in the Department of Neurology there. Dr. Monteith, welcome to the program.
Thank you for inviting me, especially on Migraine and Headache Awareness Month.
Oh, this is perfect timing then. Absolutely. So before we dive into headaches, we'd love to learn a little bit more about you. You've obviously reached high esteem in the world of neurology and headaches. What got you excited? What really inspired you to pursue neurology and specifically to help people with headache disorders?
Yeah, well, I think I had some early exposure to neuroscience working in a research lab when I was an undergraduate, and then again, kind of preparing for my application for medical school. But I was always interested in the brain and the neuroscience, and just it's fascinating and so complex, right? And in terms of picking a subspecialty within neurology, I was very excited about headache because it's something that of many of the areas of neurology, something that is treatable, something that is addressable, and can hugely impact a patient's quality of life when you get that treatment right. So I like the lifestyle component of it, as well as the science and the ability to really help people get their life back.
No, that's for sure. And headaches can be pretty darn debilitating. So helping somebody get over that would be, I'm sure you have a lot of fans in that respect for sure. Now, everybody knows what a headache is. Everyone's experienced it. My head hurts, right? But what a lot of patients ask me, what actually causes that pain? Why does my head hurt? What is going on inside that might cause it?
Yeah, so that's a great question that people have been asking for, I think, like eons. The neurobiology of headache disorders. I think, first of all, headache is not all the same. There are different types of headache, right? Headache is a symptom, can be a symptom of other problems, more scary problems, what we call secondary headaches. So it can be a symptom of another condition, let's say a brain tumor, a stroke, infection, like COVID, for example. Can be causal of secondary causes. And then there are primary causes of headache. These are things that are what we call kind of idiopathic. So for example, migraine is a genetic disorder. It's an inherited disorder with environmental factors. And that is probably the most disabling type of headache collectively, because it happens to a large group of individuals. And then there are other types of primary headache disorders that people need to know. In particular, men, cluster headache is, even though occurring in 1 in 1,000 individuals, is more common in men than it is in women. And it's considered the worst pain known to man, actually worse than childbearing. I've had patients tell me that they had been shot with a bullet and it didn't really bug them because they get cluster headaches, and that to them is the worst pain. And so there are different types of headaches. So depending on the type of headache and the reason for the headache, whether it's secondary or primary, determines the biology of the headache. So if it is related to hemorrhage, then there's pressure in the head because of this burst arteries, and that pressure effect is compressing on what we call this, pain receptors in the brain, and is notifying you, go to the ER. Right. So, but then with the primary headache disorders, migraine in particular, this is a condition which is a recurrent condition. So there's something different about the individuals that have migraine brains, the wiring of their brains, and there's a vast, even within, let's say, migraine, there could be many different causes of migraine on a genetic level. So I think, it's a warning sign. It suggests that there may be abnormal activation of these nociceptors, which again could be a warning sign, pressure effect, or it could be a recurrent phenomenon related to genetic disturbances that can turn on or sensitize the brain, is one way to think about it.
No, that helps. And, just to tease out a little bit, one important thing you had mentioned was that, if you're having a brain bleed, for instance, God forbid, right, and you're having all that pressure and pain, it's a sign to go to the emergency room. Just to kind of, since we're going to be focusing more on the primary headaches and whatnot, just to put that aside, though, as a neurologist, what are the signs that you're looking for in a patient of a headache that says, this patient needs to go to the emergency room and seek immediate attention? Or what are those red signs that we should look out for?
Yeah, so we call them the red flags, as you mentioned. And so abrupt onset, so a worst pain of your life with abrupt onset, that's kind of termed a thunderclap headache. So kind of exactly what a thunderstorm would sound like. So worst pain reaching maximum intensity, 10 out of 10, 20 out of 10 people could describe it within seconds, so less than a minute. So if that's occurring, especially if it's occurring with sexual activity or exertion, that could be a sign that there is something wrong with the brain. It could be a ruptured aneurysm. There could be other causes that are dangerous that can be associated with that. So abrupt onset, a worst pain of the life, associated neurologic symptoms. So what are some of these associated neurologic symptoms? Loss of vision, loss of speech, loss of ability to walk, weakness on one side, numbness on one side. These are neurologic symptoms that may be associated with headache that is concerning. New or different headache. So the headache may not be the worst in the world, but it's new or different. It's just a major change in the type of headache you've had. You've always had unilateral headaches on one side that sometimes it's on the left, sometimes on the right, but now you're having this constant head pain in the back of your head that's new and severe. It's very new, so seek help for that. So we said new, abrupt, severe, different, associated with neurologic symptoms. There are other things like postural, headaches are worse with laying flat or getting up. A postural type of headache could be concerning for things like what we call CSF leaks, or the high pressure that we talk about could be a concern there. And there are other things like systemic symptoms. So I've lost 20 pounds or I've lost 50 pounds. It was unintentional. And so maybe there's a history of cancer that can be associated with that headache, unfortunately, for some people. Fever, confusion could be a sign of meningitis or inflammation of the meninges, which requires urgent antibiotics or antiviral treatments. And so any systemic symptoms, older age, so new headache in an older age group can be concerning. And some of our men may have arthritis in their neck, and they start getting a new headache for the first time in older age groups. Pain is worse with turning their head to the left or to the right. That could produce a cervicogenic headache, which requires a different level of treatment. That's not really an urgent type of headache, but a new, different headache that may not be responsive to typical over-the-counter medications.
No, that's great. And these are important red flags, because this could be sometimes the difference between life and death, for sure. And not all headaches are created equal, for sure. Now, focusing more on those, what we call primary headaches, those headache disorders that you mentioned something, you talked about cluster headaches and migraines. I think tension headaches come up a lot in that group. Is there a way, obviously without becoming a neurologist, is there a way for people with chronic headaches to differentiate amongst those three in terms of symptoms? Do they feel different? Do they behave differently? That might, just give people an idea of what type of headache they might be having, for instance.
Absolutely. So you mentioned tension type headache. It's actually the most common type of headache, but it tends to be the one that headache specialists never see, because most tension type headache is mild, can be mild to moderate, and rarely prevents people from going to work or living their life. They're usually able to take something over the counter and the headache goes away. And for migraine, that can happen too. But it's very rare that someone with tension type headache would seek medical care. Now, tension type headache can have a chronic form where now you're having tension type headache half the month or more. And then that can be disabling and be a reason to seek care. But generally speaking, if you're having a recurrent headache that's moderate to severe and requiring you to talk about it, miss work, or want to seek care, then you may certainly have migraine, because migraine, we know, is a disabling condition. So while tension type headache is the most common, it's rarely a reason that people say, I want to talk to my doctor about it. So if you say that you want to talk to your doctor about your headache, even if it's bilateral as a pressure type headache, it may actually be a migraine. So primary headache disorders, migraine and tension type headache being the most common, migraine being more disabling in terms of the prevalence of the disorder, 6% of men, 18% of women, so about 12% of the population have migraine. But having said that, it's peak during the most productive years of your life. So 30s, 40s, 50s, that prevalence is much higher. And so we talked about tension type headache, we talked about migraine, and then trigeminal autonomic cephalgias is another group of more rare type of headaches. Cluster is a type of trigeminal autonomic cephalgia. It is diagnosed as a unilateral headache. So one-sided pain, it's always going to be on one side. It could be continuous, or it could happen multiple times per day. And there are what we call cranial autonomic symptoms that are associated with that. So patients can have watery eyes, runny nose, nasal congestion, drooping of the eyes. They can feel agitated with that. So that's a cluster headache, which is really important to know, because we said even though it's 1 in 1,000, sometimes it takes about 5 to 7 years to get that diagnosis of cluster headache, which is a different type of treatment than migraine, with some exceptions, and tension type headache. And certainly sinus headache, where there are some people that they think they have a sinus headache because they have these cranial autonomic symptoms, the runny nose, the nasal congestion, the redness of the eyes, and they go to get sometimes get diagnosed as sinusitis, and they get a sinus procedure, but it was cluster headache.
Oh,
so,
wow.
So that actually happens pretty commonly. And that also happens with migraine too, because we know that sinus headache is the #1 misdiagnosis of migraine. People feel that pressure pain, they feel that nasal congestion, they may get a little tearing of the eyes. They don't think of migraine because they're not wearing the big dark glasses, they're not puking like their sister is. If their sister is puking, then you have you may just have that genetics, but your headache migraine can differ within an individual, and then certainly within family members. And so really important to get that diagnosis and understand that it can vary.
No, that's great. And actually, speaking of sisters and family members, so you mentioned that, for instance, cluster headaches are more common in men, and you noticed that you mentioned a genetic predisposition, I guess, a genetic connection for migraines. Are there any other predispositions that guys should be thinking about in terms of people being more predisposed to specific types of headaches or whatnot, or is that usually about it?
Yeah, so in terms of predispositions, there's tons of predispositions related to headache. So for example, having a history of a concussion, and I think there are certainly women athletes and our soccer players. I think lady soccer players are taking the lead, right? But so a lot of the men that have sports and they've had maybe even very trivial head injuries, mild head injuries, where they didn't lose consciousness, but that type of risk, and especially over a period of time, can put a patient at risk for what we call a chronic migraine. And if that headache happens acutely after the head injury, then we call it post-traumatic headache or persistent post-traumatic headache. So head injuries could lead to concussion, post-concussive syndrome, but also persistent post-traumatic headache. And then over time, if you don't have that acute headache during that mild head injury, but later in life, a year or two later, you start developing headaches, that mild head injury, or football players and other athletes, lacrosse and things like that, can have go on to have chronic migraine or high frequency migraine. So I would say that head injuries are a major risk. There are other things like obstructive sleep apnea that can be common in our men, right? So obesity, hypertension, wide neck, snoring, apneic episodes. So this is where they stop breathing while they're sleeping. Maybe their spouse says it's snore, stop breathing. You don't always get that history, but if there's a heavy snorer that's obese and hypertensive and then has morning headaches, that's a wide neck that you almost don't need the sleep study, but you're good to get it. And then there's a treatment for that could be reversible if you're wearing your CPAP. And so there are there are a number of other things that put you at predisposition for that. Of course, migraine can be associated with what we call comorbidities. So some of the comorbidities can be having a history of anxiety, having a history of depression, which, we hear a lot about more in our women, but probably underdiagnosed in men, unfortunately. PTSD, post-traumatic stress disorder. This we see in our military population. They come back with PTSD, sometimes untreated anxiety, depression. Insomnia is a big one. So poor sleep, and some of that is shift work, where I think as a resident, right, taking call and having irregular sleep where your circadian rhythms are just kind of through the roof, and that insomnia over time can put you at risk for having a chronic headache or chronic migraine or more frequent migraine.
Got it. And actually, I want to when you go down,
another one, just to kind of the caffeine, we have all these caffeine shops. So overuse of caffeine can predispose people to, so there are a number of predisposing factors. Some of these things are easily reversible, and some of the other things are not as easily.
Let me double click that caffeine for a minute, because
as I sip my coffee, if you don't mind.
Right, and I drink my iced tea, but thank you very much. So I wanted to touch base on that for a second. So caffeine is near and dear to many people's hearts, and my understanding, a lot of treatments for headaches also include an element of caffeine. Can you help tease that out? Like, why is the caffeine causing it? And then how is caffeine helping it? Like, where do we find that happy middle ground, I guess?
Yes. Well, Mother Nature is very kind of simpler than we think, right? So it's kind of a 2-for-1 deal in the brain with the receptors. So you have these adenosine receptors that caffeine targets the adenosine receptors, and that can be therapeutic. But when overused, daily quantities, the general recommendation is not more than 200 milligrams per day, which, your typical Starbucks, they probably don't have that
Nice.
label.
Nice.
But, that's just a general kind of consensus dosing. When overused, and let's say it's the weekend and you don't have to go to work, you sleep in, you don't have that morning coffee, you may pay for it. So it's a caffeine withdrawal thing that happens, and you have to run to get your coffee, you get your coffee. So your receptors, there's something about overexposure to caffeine that changes these brain receptors that when you don't have coffee in your system can put that withdrawal. It's a withdrawal phenomenon.
And you mentioned Starbucks. So 200 milligrams, is that like an 8-ounce cup of coffee basically, or is that more than that, you think?
Yeah. So, I'm not sure about Starbucks, and, I'm a victim of it. I love it. I would say a typical coffee, American coffee that you would maybe pre-Starbucks would be about 60 or 70 milligrams of caffeine. But you really have to go online, because the caffeine doses tend to be available online, but then you have the grande and the tall and the venti. So what are these doses? And maybe you're drinking 4 cups of coffee in just 1 cup, and
Right.
and then it's concentrated.
At least
seasonal.
at least the 200 milligrams gives you some kind of guiding principle, which helps for sure.
Yeah.
What, in the same token, also I've seen online alcohol. How does that play a role in headaches?
Yeah, great question. Alcohol in and of itself can be triggering for headache, and there's been a lot of science trying to figure out what component of the alcohol is triggering for headaches. So patients with migraine are more sensitive to alcohol. Red wine is the classic thing, and the components, whether it's sulfites or tannins or other components of the alcohol, I think is less clear and still needs to be sorted out. The aldehyde component of alcohol, I think needs to be sorted out. But patients in particular with migraine tend to be very sensitive. And that sensitivity, I know some people that even if they smell it, they can get a migraine. But that sensitivity can produce an immediate headache, or it can produce a headache the following day that can be with or without hangover symptoms. And we know that patients with migraine are more susceptible to hangover than those that don't have the genetics for migraine. And so I always get the question of, well, how do I do this? I'm great except for when I drink, and I like to once a week or so with my friends, and social drinking is fine. Obviously alcohol in excess can be problematic, and so you need to take that into consideration. But there's really not a lot of good data or study or guidance to how to prevent alcohol-induced headaches. I tell people to maintain hydration, make sure that you've had a good meal, and when you start feeling that mild pressure, which comes on, don't ignore it. Just go ahead and treat it early, because it can then progress into a really horrible attack.
Got it. And one more trigger, I guess, or not trigger, but maybe predisposition that I read about a lot is stress. And people make the natural connection. Well, I'm stressed out, I get a headache. What's the science behind that, and how does it contribute?
Yeah, so stress, I think, as much as it's the number one risk factor that an individual would identify as a migraine attack, we don't have a lot of data on what about stress can trigger a migraine attack. I think the evidence is actually stronger for stress letdown. That's the period of time shortly after an acute stressful event, where that more strongly correlates to an acute migraine attack. For example, I had a big presentation, and I was stressed about the presentation. Usually you can get over that stressful meeting, but then that period of time when the presentation's over, you did an awesome job, but now that kind of stress is coming down. That sudden shift in biology or physiology can be migraine provoking. So there's obviously lots of chemical changes that are happening during the acute stressful period, glucocorticoids, changes in levels, the hypothalamic pituitary axis is altered. So a number of things are happening. And then leading up to stress is maybe you're not sleeping, maybe you're very anxious, maybe you've skipped some meals, preparing for whatever. So, but it is certainly something that people, now chronic stress is something that is also associated with chronification of migraine or increasing migraine frequency. So, acute stress is something very hard to avoid. I think chronic stress is something that we need to be more mindful of, and the role that it plays, the impact on our brains for sure, cardiovascular system or GI system. Example is a divorce. So major life stressors, even promotions that are positive things, but can be provoking of migraine. Changes in lifestyle, moving from one place to another place, and that accommodation and adjustment can be very stressful and can be migraine triggering. So being aware of these things and having good outlets are important, families, support. And I think men are becoming more open to a lot of this mindfulness behaviors and activities, both yoga, meditation, relaxation. Exercise is a good way to kind of sometimes help mitigate the effects of stress on the brain.
Well, that's great. A couple of weeks ago, we had an episode on kidney stones, and we asked the doctor, can you give us, if there's a patient in your office, said, Doc, you know what, I never want to go through this again. Can you give me 3 things I should do to avoid getting a kidney stone? And they broke it down for me. If it's the same thing here, I mean, we talked about a lot of triggers, a lot of predispositions, but in your office, if somebody comes with recurrent headaches, and obviously there are different kinds and types, but on a general level, if you can distill it down, if you can give 3 kind of ideas about 3 things to do to hopefully avoid headaches, what would the top 3 be?
Yeah, wow. That's a really great question. And maybe I would be on the beach somewhere if I could answer it, because then, I'm all about AI, by the way. You find like a robot, a Dr. Monteith robot. I go traveling, I plug in my robot, I'll be back in a couple of weeks. So it's very personalized. And so first of all, we need to know the diagnosis, primary or secondary, and then within primary, often migraine, but then we talked about cervicogenic headache, post-traumatic headache, and these different subtypes. But if we're dealing with migraine, which is, probably one of the most common things that will bring you to a doctor, then listening to their lifestyle, are they skipping meals? Do they have poor sleep? What are they doing in their lifestyle, I think is important. And then the fact of the matter is that migraines, there's no cure for migraine. So it's treatment, it's prevention, the best that you can. So treating early. So if you have a migraine attack, treating early before it progresses into a full-blown attack is really important. So making sure that you have the right acute regimen. And so having the acute regimen, treating early, preventing any lifestyle factors that might be associated with your migraine attack, and then being aware that there are prophylactic therapies, which can be pharmacological or non-pharmacological. And the idea of these prophylactic therapies or preventive therapies is that they may reduce the frequency, severity, and duration, overall burden or disability associated with your headaches. So acute treatment, preventive treatment, and lifestyle, big kind of categories, but migraine patients need to treat acutely. Prophylactic when you have some level of disability or you have more than 4 or 6 migraine days per month, you would benefit from prophylactic therapy. And then the lifestyle, trying to get at the root of the problem, which could be genetics and just like you're hypersensitive to environmental changes. For example, I'm in Miami right now. There was a weather there was a storm, lots of rain. Migraine patients are having migraines right now. They're sensitive to these weather changes. Can't control the weather. I've had my colleagues in New York reach out to me and say, how are your patients in Florida? Some of them want to move there because of the weather. Like, it's not going to help. My patients are having the same problems here too. And
Right.
so there's some things you can knowing what you control and what's modifiable and what you can't control. Hopefully that answered your question.
No,
Acute,
totally.
preventive, lifestyle, and but also recognizing that it's modifiable.
So let's talk a little bit about acute treatment, but not the prescription. Let's talk about, guys who are having mild, moderate symptoms at home, maybe recurring headaches, and they're looking through their drawers or they're looking for ideas. Okay, what's the best idea in treatment, both in terms of over-the-counter medicines and otherwise? What are the mainstays in terms of home remedies for headaches, if you will?
Right. So, understanding that there are non-specific treatments and then specific treatments. The specific treatments require prescriptions, but the non-specific treatments are your non-steroidal anti-inflammatories or ibuprofen, naproxen or Aleve, Excedrin, which contains caffeine, which you mentioned. Those are kind of acetaminophen. Those are the things that you can get over the counter. And as long as not overused, because now there's a new label warning for medication overuse headache. And if you're using it on occasion, then less of a concern about effects on the kidneys or the gastrointestinal lining. And those are first-line treatments for acute treatment of migraine.
Got it. And then other things that I want to address, though, in the same vein, you go online, you start seeing a lot of ads, right? They're not for Tylenol or Advil, I promise you that, right? So you see a lot of supplements, you see a lot of herbs. Anything in your mind that has been actually demonstrated in that vein to be successful or worthwhile in the supplement or herb category, if you will?
Yeah, absolutely. And I did a blog on this that I'm happy to share with you. But there is some evidence for supplements and nutraceuticals for migraine prevention, and I'm happy to recommend them to patients. Usually I'm not generally going to recommend this to the disabled patient that's missing work and is having a huge impact on their quality of life. Those patients probably need a pharmaceutical as a first-line treatment. But for a typical patient that maybe has a migraine 4 or 5 times per month, and really wants to try to prevent it, but wants to avoid a pharmaceutical agent for whatever reason, then magnesium, oral magnesium may be effective. Riboflavin, which is vitamin B2, may be effective. Coenzyme Q10 may be effective, CoQ10. Pitidolix, also known as butterbur, may be effective. There's feverfew that's out there. Melatonin, actually, what's used for sleep, can be effective for migraine prevention. And those are the main ones. There's some kind of emerging data about omega-3 supplementation, but it's not really yet hit our guidelines. So those are the ones that can be used. And there are some devices that are over the counter. There's a Cephally device that is super orbital nerve stimulator that you put right here that no longer requires a prescription. You do have to wear it for 20 minutes a day, but there's an abortive mode as well for it. So these are the things that can be used. And then, of course, there are other things, as we mentioned, yoga, aerobic exercise has been shown to reduce the frequency of migraine. Meditation may be helpful for migraine biofeedback. There's some evidence for biofeedback that does require at least initial evaluation with a practitioner to teach you how to do that.
What about acupuncture?
Yeah. So the American Headache Society has endorsed acupuncture for treatment of chronic headache, chronic migraine. So it may be something that is effective. I think the people that really think about it don't think that it's the particular meridians per se, but there's something about needling that produces changes in the body in this kind of neuropeptide release and is able to modulate in some ways. So acupuncture, there has been randomized control studies actually showing small studies, but showing a benefit of acupuncture. So I think that if a person wants to try it, I think go ahead and do it. The protocols for it, I think is probably less clear, but if your insurance is able to pay for it, I think coverage is always sometimes an issue, but there are some insurances better than others. And if you're able to get that paid for, and you're able to spend time twice a week going to a clinic and going under a protocol, then that might be a great idea.
No, that makes sense. And then in the same vein, chiropractors or chiropractic treatment. Now, I'm assuming, I'm going to step out of turn here. I'm assuming this has more to do with like the cervical issues you were talking about rather than, let's say, a migraine, or does chiropractic intervention might apply to all types of headaches?
Yeah. So, I'm not going to be the person that will be the spokesperson of chiropractic, just because it's just not my training. From what I've received from other patients, the chiropractic evaluation is more than manipulation, but also lifestyle and sleep. So I'm all supportive if they can give general, because we know just migraine education alone can be helpful in reducing migraine. So teaching people about sleep, diet, exercise, stress, that alone can be helpful. In terms of the manipulation, I just don't think we have good quality evidence for cervical manipulation, certainly for migraine. It's used, I think, more commonly for cervicogenic headache and for kind of whiplash injury, but there are techniques that are used for migraine that I'm just not fully versed on. As neurologists, we just get a little bit nervous about high velocity manipulations because of reports of injury to the vertebral artery and dissection, which I think the chiropractors are very familiar with, and I think would try to avoid injury. But migraine is not an important point is that up to 70% of patients with migraine have neck pain. So as we're thinking about misdiagnosis of migraine, a lot of people think it's coming from my neck. And you may have some postural issues. Everyone's virtual these days and spending way too much time in the chair and not enough time on the beach. Sure. but if you think of migraine as first of all, neck pain as a premonitory symptom, stiff neck can be a warning sign that migraine is going to even happen, because we know migraine is not just a brain disorder, but there are parts of the migraine pathway that start in the neck. And so you just have to be careful, because if it's an associated symptom, you want to treat the migraine and not chase the associated symptom, which could lead to a misdiagnosis.
That makes sense. You said something really, really important. Not that everything you're saying is important, but something really, really important was, overuse of over-the-counter medications, like whether it be the non-steroidals or Tylenol. It's not a free lunch. There's always side effects. It can always, especially if you take it too much. So, some guys will say, oh, it's okay. I get a headache. I take some Advil, and if I'm taking it every day, so be it. Right. As a neurologist, when is that line that you cross where it's like, you know what, although these over-the-counter remedies might be working for you, it's really time to see a doctor? What would be your thoughts on that?
Yeah. So, first of all, if someone is having levels of disability associated with the migraine, you should probably see a doctor. If you're using analgesics over the counter more than, depending on what the analgesic is, but more than 10 to 15 days per month on a consistent basis, months at a time, then you may have medication overuse headache. And medication overuse headache is not meant to say that you're addicted to the medication, or it's more about your migraine and your biology, and the fact that these medicines can cause you to have more headache just because they're in your bloodstream. And that if you're needing to take more than 10 to 15 days of acute medication to live your life, then you're probably better off being on some kind of prophylactic therapy. You'll still need acute treatments, but if you're needing that much, you're having a lot of headache, you're having headache 15 days out of the month or more, and you're needing acute analgesics 10 to 15 days out of the month, you could have medication overuse headache, and simply reducing that acute treatment may actually even help reduce your headache over time.
That's great advice. That makes it pretty clear. Now, the lifestyle, that happens all the time, right? One thing that everyone knows about guys, they really don't like going to the doctor's office because most of the time we're usually a little bit squeamish about what's going to happen there, right? So just to kind of clarify and make things clear for everyone on the podcast. So let's say I'm fortunate enough to get an appointment with Dr. Monteith. I have chronic headaches. I'm showing up to your office. What should I expect during that initial evaluation from you?
Yeah. So, I mean, the great thing about people that might be a little bit shy of the doctor's office is that now we have this great world of telemedicine where fingers crossed after the pandemic, they will be able to keep telemedicine, at least some major components of telemedicine, because the people that have resisted going to the doctors, or they're busy guys, right? They have also take care of kids and do shopping and have full-time job and maybe a couple jobs at a time, and then their side business and their dreams, and maybe they can't take a full day off to go see a doctor. And so telemedicine can be very useful. So just being aware that there might be different models of being able to see a doctor, I think is important. But in terms of headache evaluation and management, be aware that you are going to be asked about your history, your general health. You're going to be asked about your family history. You're going to be asked about the frequency, severity, duration of your headaches. You're going to be asked about the associated symptoms associated with your headache. You're going to be asked about, of course, these red flags that we're always concerned about, prior medication use, what prior doctors you've seen, what examinations have you had. You'll be asked about a head injury evaluation and some of these risk factors, being screened for things like anxiety, depression, insomnia. You'll have a physical examination. There'll be a question about social history, trying to understand your lifestyle, your patterns, your caffeine use, your exercise use. And as part of the physical examination, in addition to the general examination, a more focused headache examination will occur. And then, you'll get your diagnosis. Hopefully you'll get the right diagnosis the first visit. Sometimes that diagnosis may shift as you come back and said, you know what, I thought about what you said, and, I really do get this when I get, and this, then there can be a change. So recognize that there may be a change, recognize that there may be incremental care, and it may not be one visit and then that's it. Sometimes I know the stereotype of men is they like the fix, they like the solution. That solution can be over time, and don't be frustrated if you're not better within a short period of time of your visit. More motivation to come back, but you should leave with a diagnosis or at least an impression of what the problem is, and then you should leave with a plan. And this plan should include an acute treatment plan, a preventive treatment plan, a conversation about your lifestyle, and then any other things that you may have, like you maybe have looked things up online and you had questions about this. Maybe you're really scared that your grandfather had a brain tumor, and maybe that's what you're really concerned about. Or maybe your concern is that I really love playing soccer. I'm really darn good at it. I'm getting these headaches. Should I stop?
Right.
or football or something like that. So those are the things. Make sure you have your list and make sure that it's an open conversation. And, doctors these days, they want shared decision-making. They want your input. They don't want to just give you a prescription and then, okay, here's what's going to fix you. And they want your input, because if you're not going to take something, then, the plan doesn't help, right? So, be prepared to ask questions and be prepared to give your input in whatever solution is recommended.
That makes sense. Whenever you see a neurologist on TV, like in a drama or something, they're always looking at some imaging. They're looking at an MRI or a CAT scan because that makes sense. Hey, you're going to look at something. Now, guys, though, when they see that and they think about neurologists, they start seeing dollar signs, right? And saying, you know what, this doctor is going to make me get an MRI and it's going to cost thousands of dollars. I can't afford it. And the copays, I'm just not going to go. So the long story short, to what extent is imaging a part of this visit? And I mean, is it for everybody with a headache, or is it more tailored? How does that play in?
Yeah, so that's a great thing. And, on that list of plan, I didn't mention diagnostic testing. I should have mentioned question mark diagnostic testing,
right?
Because if you get a good history and you're convinced it's a primary headache disorder, there's a strong family history, it's recurrent, there are no of these red flags, you may not need any imaging. And so oftentimes in my clinic practice, now I do see a lot of people, I'm like the fifth referral, and they've had 20, 100 tests by the time they get to me, but I don't always order imaging. So imaging may or may not be warranted when we think it's a red flag and we think it's urgent, let's say 70-year-old gentleman, 60-year-old gentleman with unilateral headache, never had headaches before, you got to think about temporal arteritis, and that's a blood test. And so when the doctor says you really need to get this, get it. When the doctor says, it may be we just see you back, and should things get worse, then we can consider it, then that can be a consideration. If I think you raise a really good point that if someone has financial concerns, and we all do these days, but if there's like significant financial concerns, I think you need to voice that, because there may be tests that are hopefully there's insurance coverage, but if there's not insurance coverage, there may be some other tests that are less expensive and will give us some level of information, and better than not getting any tests. And so, we live in a day that this is not socialized medicine. If you go to one facility versus another facility, there may be differences. So that might be where the patient also needs to engage and kind of research different places to find the adequate cost. But it should never be that I'm going to avoid seeing a doctor because I'm afraid of getting a diagnostic test that I can't pay for. You got to speak up, and then we have to feel comfortable with working with you in trying to make sure that we do so safely and we treat your headaches effectively.
Makes a lot of sense. To sure, that would be reassuring for a lot of people out there, for sure. Now, I loved how you phrased like a full treatment plan that involves preventative and treatment and lifestyle and whatnot. A lot of the guys out there are interested in the actual medications, right? So, like again, if the over-the-counter stuff doesn't work, the neurologist is going to prescribe potentially some medication. Can you go over maybe some of the top ones that are prescribed and kind of like what to expect from them potentially?
Yeah. So I guess we can talk about migraine and cluster headache. We can talk about post-traumatic headaches if you like also. Sure. I think those are kind of cool, good categories for men to discuss. Absolutely. So we can start with the cluster headache, which is, again, 1 in 1,000, unilateral headache, one side of the head, around the eye, but frontal temporal region often. And then the cranial autonomic symptoms, and the nasal symptoms, congestion, a runny nose, red, watery eyes, droopy eyelids, and occurring typically between 15 minutes to 3 hours, around 40 minutes, could be multiple times a day, every other day, or up to 8 times per day, and it's usually seasonal. So happening maybe in the spring and the fall, and can last for weeks to months at a time. So that's cluster headache. And so those types of patients, interestingly enough, respond to oxygen. Inhaled oxygen can abort a cluster attack. Wow. And sumatriptan, which is a medication that targets a receptor, serotonin receptor. Serotonin, many people know a little bit about, but serotonin in the brain, but not just serotonin receptor. That receptor does other things, such as lower peptide called CGRP, or calcitonin gene-related peptide, which we're also going to talk about. So serotonin does targeting that serotonin receptor. So with sumatriptan, those are the two ideal abortive therapies for cluster headache. And then there's prevention. Verapamil is kind of the old drug that's been used for treatment of cluster headache. Steroids, that's more of a transitional therapy that's used to try and break the cluster bout or reduce the frequency of the cluster attacks while you're getting that verapamil level up, because oftentimes you need to escalate that level. And then there's a newer treatment. We talk about calcitonin gene-related peptide, that there's a medication called galcanezumab, which targets CGRP, and it does so as a monoclonal antibody. So kind of with COVID, everyone's getting these monoclonal antibodies, but you can actually produce monoclonal antibodies to many things, including targeting the CGRP protein. So basically acute preventive, the same way, with oxygen being first line for acute treatment of cluster headache. And there are other things like melatonin that can be considered. Avoiding alcohol during the cluster bout, because we know that alcohol is a potent trigger of cluster attacks. And so that's kind of cluster headache in a nutshell. There's certainly other treatments that can be used. greater occipital nerve blocks, injections in the back of the head for cluster headache. And that's an interesting one, I think, as a urologist, because you test some of the hormones. Testosterone can be lower in individuals with cluster headache. And so it's just a very interesting disorder. And in terms of, we'll talk about concussion or post-traumatic headache. There are no real standard treatments for post-traumatic headache. Post-traumatic headache can actually look like migraine at times, more commonly, or can look like more of a tension type headache. It can even look like cluster headache. So you try and treat that post-traumatic headache, what it most resembles, the primary headache that it most resembles, which oftentimes is migraine. And of course, preventing the next post-traumatic headache is a big part of treating patients, because of repetitive concussion can put patients at risk for more concussions and other cognitive impairment and other issues. And then so migraine is kind of the big category. And in terms of the pharmaceutical treatment for migraine, as we mentioned, there's the acute treatment, the non-specific, the non-steroidal anti-inflammatory, which can be prescription. The triptans, there are 7 of these triptans, these serotonin targeted drugs, which are for acute therapy. And as those are the main ones. There are other things like what we call neuroleptics. These are medicines that target dopamine in the brain, but actually can have headache relieving properties. And just kind of talking about these general acute classes, there are different ways to administer it. So nasal sprays up the nose, in self-injection is one way. A pill is what patients tend to like the most. There are even melts that people can use. And then there's these newer classes of acute treatments. And these are these CGRP medications that target the receptor. So calcitonin gene-related peptide receptor antagonists, basically blockers of this pathway. What is CGRP? So CGRP is a peptide, a neuropeptide that signals pain, but it's involved in other things. It's a potent vasodilator. It also, or kind of expansion of blood vessels. It's also associated with inflammation. So it has a number of roles, but it's very important for migraine and part of the migraine pathway. And so targeting CGRP can be done with monoclonal antibodies, which we spoke about, a fancy way to inject yourself once a month. And at home, the patient can do that to prevent a migraine attack. Or acutely, they can use a pill or a melt in the mouth to stop an attack. And when using these pills every other day, there's one in particular called Remedies that can be used for prevention. So there's Remedies for prevention or acute. There's Ubrogepant for acute, and you can look up which star is advertising what. And then there are 4 CGRP monoclonal antibodies, one through the IV, which you have to go to an infusion center, or these days they can come to your house, eptinazumab. And then there are the 3 other CGRP monoclonal antibodies, galcanezumab, feminazumab, and arenumab. And they have some slight differences associated with them. So these are kind of the newer agents. And then there's Botox injections for prevention. And Botox injections are right now FDA approved for the treatment of chronic migraine, which I think we mentioned, 15 headache days or more. Half of those days feel a lot like migraine. And it's been going on for at least 3 months. Botox injections are something that I love injecting men. They're happy to get the injections. And you still got to make them feel comfortable getting the injections, but they're very quick and it's only every 3 months, and they can be very effective, something that you can avoid using oral treatments prophylactically. And then of course there are non-specific oral treatments, the old stuff that we've not really discussed, Topamax, which is the anti-seizure drug, Depakote, Divalproex, another anti-seizure drug. There are blood pressure medicines. Even if your blood pressure is completely normal, you may respond to some types of blood pressure medicines or antidepressants. Those are the kind of the older non-specific things, versus the CGRP drugs are these kind of targeted therapies specific for migraine, which is kind of cool. So we talked about the acute treatment, we talked about preventive treatment, we talked about a little bit of the lifestyle interventions as well. And then there are devices. There are 5 devices that are FDA approved for migraine, some of them for acute, some of them for prevention, some of them for both. There's a vagal nerve stimulator that you can stimulate the vagus nerve as it comes up the neck. It's called a gamma cord device. There are others that are very effective potentially for migraine. Cost can be an issue because insurances are not necessarily paying for some of these devices.
And those devices are prescription or they're over the counter?
So the Cephally device, which stimulates the supraorbital nerves, it is that's the one that does not require prescription. The other 4 do require prescriptions.
And the targeted therapy with the antibodies and whatnot against seizure, that's amazing. I mean, that's like really kind of state of the art. That's what people want to hear, right? It's not just kind of some generic treatment and stuff. Are those pretty well tolerated? Do those have any major side effects at all?
I feel like you've been to my conference. You're asking like all the right questions. And so the long-term studies now, the first one that came out was arenimab in 2018, and the three others followed. And so the long-term data is it's strongest for arenimab, but fremanazumab and galcanezumab also have long-term data. And the concern of, we talked about these CGRP calcitonin gene related peptide being important for being a potent vasodilator, so that mechanism with hypertension. So a lot of these long-term studies have looked at cardiovascular patients with hypertension, some with cardiovascular disease, and it seems like long-term studies show that these are very effective and safe drugs.
That's fantastic. I mean, that gives a lot of hope to people out there. And again, it's so exciting that we're getting to the really root cause and really attacking that rather than just kind of, if you will, putting the proverbial Band-Aid on. We're really hitting where it's most effective. And that's fantastic, especially with low side effects. So I salute you with that. That's amazing. And I'm sure it will give hope to people and I think impetus for guys to come to see the doctor, because they know that I'm going to be getting. And what I really loved was that you're getting a comprehensive plan. You're not just getting take 2 of these and call me in the morning or don't. It's more like, okay, we're going to figure out a way how to treat it acutely. We're going to figure out a way how to prevent it. We're going to keep it a way to maintain it. Lifestyle, just a holistic approach with also state-of-the-art, cutting-edge treatment modalities, which is fantastic. I mean, I personally had no idea that the world of headaches was so far advanced. It's amazing. It's really amazing to hear. And I'm sure guys would be really excited that there's hope out there for them, for sure.
Yeah, I think, as you say, some guys don't necessarily access care the way they should. And I also think that they don't necessarily know the power of some of these interventions could totally turn their life around, make them a better dad, because they're not in bed. It's kind of like sluggish. And it's not so much that some people are super disabled and they're in bed, they're puking, but then there are others that they have the pain. It's more than the pain. It's the other symptoms too. It's kind of the lethargy, that kind of lack of spirit per se, that kind of brain fog where you're typing that email, but you almost have to retype that word again, and you're not as functional. And with treatment and intervention, you get back to that person that you are. And, it can wear on you. And it's not just the acute attack, especially for migraine, but there's what we call the interictal burden, or the interictal period, where the processing may be a little bit slower, even between attacks. That kind of low-level light sensitivity may be present, where you don't really, and some of these symptoms sometimes kind of can creep up on individuals. Kind of persistent nausea can happen in between attacks and you're not fully aware of it. There's the acute attack, but there's also that period before the attack that we call a prodrome or premonitory phase or symptoms, where you may have the irritability, fatigue, you may have some nausea, you may have some sensitivity, light or sound. You may find yourself yawning very frequently. And then you take something, you have the attack, but then the attack is gone. But is it really gone? The headache may be mild, but you have that kind of hangover phase. So
Right.
it's more than just a headache. It's this kind of neurologic event. And then there are other patients that describe other interesting symptoms associated with their migraine attack. And that over time can really have an impact on your quality of life.
Yeah, that hidden burden that you're not noticing. And again, when the pushback you'll hear from guys is, I'm not going to go to the doctor, they're just going to tell me to take some Tylenol. I'm doing that already. But obviously there's so much nuance there, as you've shown. This is not one hammer for one nail. There's a lot of different nails out there, different ways to manage it, and a really comprehensive plan, which I think guys should be take notice of, for sure.
Yeah, and another thing that I've noticed that people start off, and this might be true of other areas in healthcare, but people come in the door to try and fix this problem, and then you're trying to get to the root, but then you're uncovering other things, and then you're really focused on the headache, and I really just want to get rid of that. But then at some point, you're like, okay, well, I want to fix my sleep now. Okay, yeah. Well, I want to fix that stressor and that communication that I'm having with, and I want to start exercising. My abdominal obesity, not happy with it. What kinds of food should I be eating? And first it's those to avoid a migraine attack, but now it's like, I want to improve my brain health. I want to prevent myself from having a stroke. There is a link between migraine and stroke, migraine aura and strokes, not large in the population, but it does exist. And, what about that tobacco? I think it's time for me to stop. And so it does kind of, in some ways, get people in the door because when you're seeking help, it's the migraine that's bothering you. And sometimes it's more than just the pain. Like I mentioned, it's the vertigo. It's hard to ignore vertigo, right?
Yeah, that's for sure.
Can be a symptom of migraine. And, but it's kind of a way that people say, I'm ready for healing. And and that can also creep up on you.
For sure. Dr. Monteith, thank you so much. This has been extremely helpful and informative, and frankly inspirational, I'm sure, for a lot of guys to go seek help. Before we let you go, I have one question completely unrelated to headaches, or maybe not. Just the name of this podcast is Better Man Clinics. The whole idea is to become the best person you possibly can. You've obviously reached a great level of success in your life and continue to. What is the secret to your success? How do you live your best life?
Oh, wow. Really?
There's a curveball for you.
I don't know that I was ready for that question. Great question. I think listening to myself, listening to others, and knowing that, being conscious that opportunities exist. In a way that if you tapped into all of your opportunities, it may be an avalanche for you. And you probably wouldn't be prepared if you kind of on a very conscious level, because there's really so much available for us in this world. And so listening to what your heart desires, not ignoring that migraine when it occurs, but, are there other things that you've been pushing aside within yourself? And trusting the process. I think trusting the process, listening, and just being conscious of the opportunities, even though you're not going to be the one that's going to figure it out today, but just being open to the opportunities knocking on your door.
Such a great point. We spend so much time with our heads down, trudging along, and just, getting from one day to another. We miss all that amazing opportunity that sits outside of us and inside of us as well, that are kind of knocking very quietly, but we don't always take the call. Really appreciate that. I think that's great advice. Dr. Monteith, thank you again for joining us. And for all you guys listening and watching, thank you. And remember our mantra here at Better Man Clinics: your best life is a journey and not a destination. And choose every day to get just a little bit better. We'll see you all next time. Take care.